Thank you, Dr. Shaib. Now we'll start the next session, which is about case discussion. The first case will be complex perianal disease, anti-TNF experienced patient. And this case will be presented by Dr. Abdualelah Al Mu. Dr. Abdualelah Al Mu is a consultant gastroenterologist at King Faisal Specialist Hospital and Research Center in Riyadh. He is assistant professor in Al Faisal University in Riyadh. He is the current director of Adult Gastroenterology Fellowship Program and the quality director of Department of Medicine at King Faisal. He is a graduate of King Saud University, completed his Saudi and Arab Board of Internal Medicine, and he completed his Saudi Fellowship of Gastroenterology. He has advanced clinical fellowship in inflammatory bowel disease from University of Calgary in Canada, and he is a member of Saudi Gastroenterology Association. Dr. Abdualelah, a dear friend and an expert in IBD, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Malak, for this nice introduction. I'm not the expert. I hope I'm one of the colleagues who are running and seeing IBD patients in Riyadh in Saudi Arabia. Honored to be part of the speakers in this elegant and nicely organized conference. So congratulations to you guys in Kuwait for running such a nice conference, competing with those done in Saudi Arabia and across the world. So I'm challenged with 3 experts actually in the panel, so I will be this time giving the questions. After listening yesterday to all the theoretical part, the evidence, it's time to apply the evidence. So I will be sharing with you one of the difficult cases that we encountered together with colleagues from King Faisal Specialist Hospital, a young patient with Crohn's disease. As we go through the case, we'll have some stops where we will ask the panelists to share their ideas, their thoughts, if anything that we missed in our hospital. And actually I came with the mindset of exchanging the experience, kind of like if there is any ideas to help such patients, I would love to hear from you guys, from the panelists, so we can take that back to our patients as well. So this is a 15-year-old gentleman. And just for the international speakers, in Saudi Arabia and maybe parts of the Gulf, we start seeing, adult patients from the age of 14 instead of 18. So this is a 15-year-old gentleman who was referred from colorectal surgery clinic, and the initial documentation by our colleagues in colorectal surgery. He was complaining of right lower quadrant abdominal pain, recurrent perianal abscesses that started 3 months back. His history goes back even 2 months earlier with recurrent perianal abscesses that opens and drains spontaneously. Also associated with diarrhea, low appetite, and undocumented fever. He lost around 20 kgs in 3 months. Is otherwise medically free before. No family history of inflammatory bowel disease, other immune-mediated inflammatory disorders, or malignancies. Might go superficial with some of the history data just to have the case going. The patient on examination was vitally stable, alert and oriented. Abdomen was mildly soft and lax, but he had a tenderness in the right iliac fossa as per the documentation, and even the examiner was having difficulty eliciting what was the finding. There's no clear documentation about a mass. The rectal examination showed 2 fistulae, one at 2 o'clock and the other one at 9 o'clock. Both were tender, and the labs showed a leukocytosis of 17, hemoglobin of 11, with low MCV, low MCH, kind of iron deficiency like, with an albumin of 27 in the context of his 20 kg weight loss, and a CRB more than 300. And this is just, a thought-provoking, lab. When you see a CRB more than 300, you start thinking of something beyond disease activity. So this is what his imaging was showing. You can see in the right side here with the red circle collection that is tracking in the right iliac fossa across the ileocecal area. In such patient with such tenderness and high CRB, this is an extensive right lower quadrant inflammatory changes with large abdominopelvic abscess measuring around 21 by 7 by 7 centimeter. So the patient was scoped by colleagues, and just keep an eye on the date. This was in 2019, late 2019, early 2020, and this is relevant to the case discussion that we will have soon. So you can see the patient's disease, and you can, hopefully the pointer will work. So you can see this is the rectal disease on the left upper corner, while down here is the ileocecal valve, And this is the attempt in the right lower corner, attempt of the endoscopist to intubate the TI, but with difficulty. So eventually they failed to intubate the TI. So this is their findings. He had 2 openings of perianal fistulae. Mucosa of the rectum, sigmoid, distal descending were severely inflamed, covered with mucopurulent exudate, only small area in the proximal descending, transverse colon, not involved, so normally, completely normal. They able to comment that this is skip lesion. And then at the cecum, there was distorted ileocecal valve with ulceration, a large fistula opening, and they could not intubate the TI. So an ileocolonic, mainly left colonic and perianal disease, this is the disease extent in such patients. So this is my first stop, and I will just give the mic now back to our colleagues panelists. What would you do next?
Yeah, thank you. This is, first of all, we have to keep in our mind that this is a youngster who has got all of his life ahead of him. Okay, so keep that person in mind first. Clearly, he has got, even by 2025 standards, he fulfills all of the Buchery criteria for high-risk disease. He's got perianal fistula, he's got complicated phenotype. So he does need treatment, but he also has a complication first. So we need to deal with that complication. Either, this is eminently possible looking at the imaging for drainage, antibiotics, and then very soon after, I would start top-down therapy. I would recommend starting top-down therapy with combined biologic and immunomodulators. And yes, I have a slight bias towards anti-TNF, so that's what I would do, anti-TNF along with that. So almost like a triple therapy of
So you're saying 2 stages. I mean, treat the abscess first, and then treat the cause of the abscess. Okay.
I think the abscess drainage should be fairly immediate. And these are mostly sterile abscesses. Yes, you would give him short period of antibiotics, perhaps for benefit of doubt, but soon after I would put them on treatment.
Now, let's direct the question to you, or Dr. Abdualelah. If the IR told you it's not drainable, it's not accessible, what will you do?
Yeah, that's a good question. There are some abscesses which are not drainable through IR. In that setting, I would perhaps try brief period of antibiotics and see and re-image. Now we got much better. We got experts in intestinal ultrasound here. This one doesn't necessarily need CT-based follow-up as such. That may be an option. Would I drain surgically? He has lost 30 kilograms body weight. He's sarcopenic. His outcomes from surgery will be, yes, stoma is inevitable in that setting, but outcomes from surgery may be difficult. So I will try interventional drainage antibiotics, but also, put off the fire, because this is driven by the disease. So I would give that together.
Would you give steroid at this level? Dr. Gami, go ahead.
Sorry. I think the additional thing that I will do extra is to do mapping for this guy. Because mapping, like I just have a CT that showed an inflammatory phlegmon or an inflammatory area in the abdomen and in the pelvis. I'm not aware about the fistula that was initially seen in the endoscopy, whether it's an enteroenteric or it's something else, or it's not a fistula, it's a blind opening as well. So MRE would be an additional option beside all the step that will be carried out. And with regards to antibiotic, the studies were only supporting the metro rather than the Cipro. So the metronidazole is the antibiotic of choice in his case.
No.
Agree.
Yes. Yep.
Yeah. We need to see the pelvis and we need to map the disease in the small intestine.
Just to keep it, will you consider EEN for such patient?
So usually nutritional support is a challenge. Depends on the surgeon you were working with. At least in our center, our surgeon tend to believe in bowel rest and parenteral nutrition, while we tend to push always for enteral nutrition since the evidence is there that enteral nutrition, as long as there is no contraindication, is preferable over parenteral nutrition. Some patients, selected patients who continue to have an abscess despite initial antimicrobial over a few weeks and failed drainage through IR, we might elect to go for an MBO PN, but this is again very selective. So the general rule is yes, enteral nutrition first, and then a failed or selected group of patients, parenteral nutrition, either as supplemental or total, is an option. Okay, so steroids, anyone would go for steroids now? On top? Okay. So let's go for what happened. So the patient was started analgesics, antimicrobials, IR-guided drainage of the abdominal collection, as mentioned already by our experts, pre-biologic workup to consider, so this is not started yet, to consider starting infliximab after the initial drainage. The surgeon, the patient was admitted under a colleague surgeon, decided to discharge, and after consultation, they put him on steroids since they are saying, we don't think we'll take him for surgery now, we want him to cool down. And our gastroenterologist, they were back and forth regarding steroid, but eventually put the patient on steroid, Cipro, not Flagyl, as Dr. Rim mentioned, she wanted metronidazole, and then a drain in situ, and the patient was sent home. He returned after 2 days with non-functioning drain, with all pus leaking from the insertion site. And I will just go with you over the case since there are a lot of stops in the future. So it was discussed, and then a decision was to go for surgery, and this is one of the cases where PN was started as total parenteral nutrition, with MPO, and then the patient eventually went for laparoscopic ileocecal resection with ileocolic stoma formation. Now we are in the post-operative phase, which is February, April 2020. I remember in Saudi Arabia, March was the month of the closure for COVID. So the pathology showed positive margins, granulomas. The patient has documented Crohn's disease. Pathologically, he was clearly Crohn's from the beginning, so we're not questioning the diagnosis at this level. He had a temporary stoma. He's recovering smoothly clinically. What's next? When to start? Would you start treatment now? What is the option? When to start it? So again, would you go, Dr. Sebastian, as you mentioned earlier, or Dr. Reem, what would you prefer? When would you start?
Yeah, I just want to go back to this thing, and perhaps it's for learning for all of us as well. There is now sufficient evidence of rather adverse outcomes with use of corticosteroids in perianal fistula patients alone. So it's our practice not to use steroids even if there wasn't this walled-off collection. So I don't think we, for future at least, we don't probably use that. That's just for everyone in the audience. I would be also interested to know, is there any surgeons in the audience who believe in sort of really perioperative optimization? This patient will need surgery later along with treatment of the disease. So perioperative optimization, what you said about TPN and other things is relevant. So where would I go next? Again, I go back to what I said. This is a high risk phenotype of disease. I will hit him hard, top down, because we need to work on that along with nutrition and along with his, this would have hit him hard. He's got at age 17 or 16 now or 17, he's already got a stoma and he's got an incurable disease. So we need to work at that level as well for him.
Dr. Sebastian, do you think from the beginning he should go for surgery, surgical resection, stoma? Is it part of the hitting hard to go top down surgically first, or you still believe give anti-TNF or biologics and then that's the top part we can go? Surgery is not a part of treatment?
Yeah, I think when we talk about the role of surgery in Crohn's disease, we have two arms. Like a patient in emergency situation, like perf, urgent situation, where we are blinded in this case, we don't have any history, we don't have any mapping, we don't have anything, then it's a must. But if we are looking on the recent published LIRAC trial about the role of early surgery for structuring Crohn's, The inclusion criteria, where they published or highlight the fact that the mortality and the morbidity in the first year and 10 years after on the follow-up is way less in patients who were operated early. Looking at the inclusion criteria for this patient didn't have a pre-stricturing dilation. And the criteria said the stricture area need to be less than 30 centimeter. And that's a really big segment and a very vague definition. For a patient with underlying a cooking sepsis and unclear margin, I think the decision of surgery, which is already taken, it wasn't like an optimal decision to be taken. The option that I have beside the mapping, I agree with Dr. Sebastian that I would go for biologic treatment after covering up with antibiotics. With regard to the option.
How soon would you start?
The rule would say 4 weeks up to 3 months is the early window to start after making sure that the sepsis has been controlled.
Now, this is a practical question that we usually face by the patient, by the surgeon. They're saying, we'll take him in 3 months for reversal. Would you start? Would you recommend them against reversal now? Keep in mind, this patient in particular has a residual disease. He has left colonic disease. Would diversion alone kind of control the left colonic disease per se, or would he really in a bad need for biologic to control the residual left colonic disease? So this is kind of an argument that you usually take with the patient. Now you took the disease out and I'm waiting for the stoma reversal. The surgeon is telling us to hold biologics. Some colleagues, you know that, and we know that evidence is against this, but again, you need to discuss this and negotiate that with your surgeon. This is how life goes. In that context, a time of reversal of the stoma, a timing regarding biologics, and definitely I think all of us, we agree on an anti-TNF in such high-risk patients, but the timing, before or after the reversal?
No, I think that is, this is where we need to really work on an MDT setting. This patient does need a proper MDT meeting with a surgeon included in that. There is practically very little evidence now that once if you have confidence that the sepsis is cleared, and in this patient I think it's mostly walled off collection, I would have no hesitation in starting them early. I agree in some centers and some surgeons will be a bit reluctant, but for me the fire is still running. I'm a simple clinician. He's still got the disease which is running there. What we have fixed is a complication. I would optimize his nutrition straight away. I would start him on treatment right away. In fact, I would argue that doing that will likely make his reversal more under optimal conditions. His nutrition is controlled, his disease, perhaps even the rest of the disease is better controlled. So to me, I won't wait. I would start. So for us, we have a perioperative nurse practitioner who goes and sees the patient, and usually straight after surgery, most often usually within the following 4 weeks, the treatment is already started.
So if it's in clinical setting, to Abdualelah, I'll sit with the patient. First we'll sit with the MDT and patient and his parents, most likely. He's a 15-year-old boy, so keep in mind his parents. So he's a young chap with a stoma. At the same time, you have to explain to him that the stoma is helping him at least this is the best time to optimize treatment. You have a stoma, his fistula, perianal fistula now is most likely maybe less active compared to before. So this is the right time, as Dr. Shaji said, to give your treatment. Once you control the disease, then you can talk about reversal. So definitely won't reverse him now.
I think the decision to reversal would be 4 months and after. That's depend on my scope. So I would do scoping 4 month to 6 month period from initiating the treatment, which will be started 4 weeks from controlling the sepsis and the surgeries, I mean the biologic treatment. And then I would go to evaluate the healings with the biologic, whatever biologic I started, and then I would evaluate him in 4 to 6 month period by scope, and then I will decide whether he's good to go for reversal or not.
Okay. So it seems that you're gonna scope through the stoma and scope as well the colon, and usually we'll be faced with this diversion dilemma. Is it diversion colitis or not? The question from Dr. Hamad.
So as Dr. Sebastian and Abdualelah young, ileocolonic disease, perianal fistula, involving the colon, involving the small bowel, this is very critical case. So in this case, if we decide to start infliximab, you will start higher dose because this is perianal disease, and you are going to give immunomodulator also. So you are going to give immunomodulator and high dose or shorter period of infliximab?
No, I think all perianal fistulas we give 10 milligram per kilogram along with immunomodulator, along with 4 weeks of ciprofloxacin based upon the Adafi trial. Yes, it was using adalimumab Adafi trial, but so that's our standard protocol for perianal fistula regardless of the case. All of them get 10 milligram per kilogram upfront. We aim for week 6 levels to be well above 20, and maintenance levels well above 12 and probably closer towards 15. So all of them are given that regime. No, we give ciprofloxacin based upon the Adafi trial where 4 weeks of ciprofloxacin had increased response rates. It's a proper RCT from Amsterdam.
So I have, actually the case has a lot of phases of stops, so I will walk you through this, bearing in mind that there's still a lot, it's 2020, we have 5 years to go. Okay, so what happened that before discharge, the GI team saw the patient, gave him an appointment in 4 weeks, this is what we tend to do, to initiate the discussion about infliximab, and given actually day medical unit as well. Unfortunately, with the COVID, I don't know what was the reason there, but the patient did not show to the GI clinic in 4 weeks. He came to surgical clinic in 3 months after, doing fine. Due to COVID situation, the surgeon documented that at that time the OR time was limited for only emergency surgeries, and he was not deemed as an emergency. Unfortunately, there was no clear communication as well with the GI team to start something. Whether the patient was afraid because biologics, immunosuppressant, and the level of or at the era of COVID, but eventually there was documentation that the patient will not have closure soon, and he was given a clinic appointment, and again he's off treatment, he's not on anything. He came 6 months after the surgery, clinical remission, luminal and perianal, CRB is 4.7. It's planned for combo infliximab azathioprine, but this is already late beyond what we wanted. The patient missed a day medical unit, unfortunately, 3 times, because the family wanted to proceed with the surgery. They were afraid of further delay if they start infliximab. So September 2020, this is almost 8 to 9 months after the initial surgery, ileostomy reversal was done. In October, 1 month after the stoma reversal, he came to the GI clinic. He's sick, vomiting, bloody diarrhea, fever, admitted. His leukocytes were not bad, but CCRB was 240. That dropped quickly to 50. His fecal protectin went to 1,000. CMV, C. diff, and so CMV in the blood, C. diff in the stool was negative. Septic screen was negative. We started antimicrobials, started steroids. His CT again showed signs of active proctocolitis, and then minimum free pelvic fluid, no collections, and there is resolution of the previous collection as expected. It was not scoped because of the recent surgery, and then the team decided to start the first dose of 10 milligram per kg infliximab, and was discharged after showing clinical improvement. So at that time he was on infliximab 10 milligram and steroids. So he got 2 infusions of infliximab together with azathioprine, with steroid and Bactrim as BCG prophylaxis. He came to emergency twice while he was waiting for the 3rd infusion of infliximab of 10 milligram per kg, and given 2 courses of antibiotics with abdominal pain, diarrhea, and fever. Despite the 3rd infusion of infliximab, he came back to emergency. The level was requested, but it wasn't available, unfortunately, that time because they sent out tests in our institution. So after the 3rd infusion, azathioprine, steroid, WBC is 7, CRB is 163, C. diff, and again CMV is negative, albumin is 26. He's starting to lose weight. CT again in the emergency after the 3rd infusion is showing now an interval development of a DVT and the PE. So the patient is having active colitis, evident by VTE more, and at that time he was scoped, and you can see, at least he underwent a sigmoidoscopy, not a full colon. You can see how active the disease in the left colon, in the rectum, and the sigmoid, and the biopsy did not show any CMV. So this is my second stop. What's next? Would you continue infliximab? Would you consider switching, and if you switch, what agent?
So basically we are dealing with complex IBD and DVT/PE patient. He needs to be evaluated by the hematology to start anticoagulation. That's no doubt in that. With regard to the biologic, I think it's too early or too soon to decide on the infliximab. He just received his third dose, as far as I know. I would continue for steroid, and I would go with the infliximab till I have like a TDM or a trough level. Whether or not I'm starting him on something stronger or I'm stepping up, my threshold is still low for that. But given the fact that if what's my option, especially in a patient with DVT and PE, what's my option? Like if I'm considering something like UPA.
And this was just, if you'd allow me to interrupt, 2020. So
Yeah,
the available agents were anti-TNF, two anti-TNFs, anti-integrin, and anti-B40 or interleukin 12/23. These are the available options that time in our institution.
Yeah, so the fact that he failed infliximab to start with, I know sometimes it's not the ideal situation to know why the patient failed it. Is it mechanistic? Is it autoimmune? Is it all these things? Sometimes it's not the optimal situation to decide. So maybe another course of steroid and another infusion of infliximab with the trial of TDM and antibodies, and then I will decide.
How many infusions would you just pull the trigger and say, that's it, with infliximab, I will move? How many further infliximab infusions, since you're recommending to continue?
I think the guideline now has been shifted to lower threshold. So the TDM now is measured at 6 weeks period, okay? The usual studies was on week 12, and now we are shifting to 6 weeks. So in terms of the time span where he is.
Okay. Any other thoughts? Continue, discontinue infliximab, or do you agree with Dr. Reem?
No, I agree with Reem that it's too early to discontinue. I would check his levels. You know, he has all features to develop early antibodies as well. Yes, he's on thiopurines. I'm aware of that. I just got a sneaky, this patient should be discussed in an MDT. I got a sneaky suspicion. He's presented 3 days after reversal with a high CRP with abdominal pain and vomiting. He probably had a subclinical leak at the anastomosis. So this imaging needs to be really looked at, to be honest. I don't think steroids are the right in this setting. I know you had a CT, whether that has been looked at properly at an MDT setting with a GI radiologist.
So continue infliximab. So the team that time did not continue infliximab, and they preferred to switch. And he was labeled as primary non-responder, relying on non-clinical response at all, even with steroid. So they moved to IV stickimab, continue azathioprine, and they added Bactrim. So again, I know just maybe have 5 minutes to go for the case, but I have a lot. I will be going quickly if you'd allow me. So the patient, 6 months after, he was on a stickimab Q4 weekly upfront, not the Q8 weekly, and I'm just disclaimer here, we're going a lot of off-label or kind of like some medications dosing that we need to discuss usually in our formulary with our colleague pharmacist before going for such. So he was continuing on stickimab Q4 weekly, azathioprine, anticoagulation. He feels better overall, starting stickimab. Had 3 to 4 times bowel habits. They are bleeding minimum once per day. Mild abdominal pain, improves after defecation. No new perianal collection or fistula. His hemoglobin is 120. His platelet in the higher side. CRP is still 70. And fecal protectin was more than 1,000 and now a 900. So, sorry. This was 8 to 9 months after starting stickimab, improved. His labs again are kind of stable-ish. He had a C. diff, started on vancomycin. This is in December, almost 9 months after stickimab. And this is his scope. So this is February 2022, kind of 1 year after stickimab with azathioprine. He had some clinical gain initially with stickimab, but recent worsening. He was admitted, the sigmoidoscopy, and you can see the deep ulceration in the rectum, the sigmoid. He started to have those cobblestoning and inflammatory polyps. And even the colleagues are not able to push the scope further. So at least in the sigmoid, he has a SESCD of 9/12 and a rectum as well, a similar SESCD with fair load of disease severity. February 2022, his MR pelvis showing persistent diffuse colorectal distal ileal. So now we're talking about ileal left colonic disease despite the current treatment. He has a healed kind of fibrosed perianal fistula, but small active right perianal sinus. Was discharged again on steroid. They re-induced with sticknumab, and they preferred to change going with labeled combination. So they preferred to change azathioprine to methotrexate subcutaneous, and again steroid once less than 10 to introduce the methotrexate to avoid triple combination. He was having recurrent C. diff, so he was on a pulse tapering vancomycin as well. In October 2022, still having 6 to 7 times bowel habits, CRB in the range between 30 to 40, albumin is 23, his WBC is 3.9, hemoglobin 136. So this is on sticknumab, methotrexate after a failure of infliximab. Was scoped again after methotrexate. He's still showing the persistent disease, the deep ulceration. Whether we missed the opportunity for continuing infliximab or combining at that time, the team preferred to go for, as in labeled indications rather than off-label. So what is next? Would you pull the trigger? Would you consider switching to vedolizumab, which is an anti-integrin? Would you consult a surgeon? What's next?
Clearly, this is, cases which humble you. He's got complex disease. I wanted to just ask a couple of little things. Yes, he was 15. Have we checked his whole genome exome? That's one thing. Second, in his case, I would go back to what I said, hit him hard. I would even at this stage give him combination treatment, but combination treatment along with an anti-TNF rather than adding Vedo. Vedo has got some data in Crohn's, but I think it is not for this severe type of disease. So that's what I would do. I would check his whole genome exome, do a whole genome exome sequencing on him, and also give combination therapy at this point of time. Surgery should be discussed because he may well end up, but he has progression of disease. He's got progression in the colon and in the ileum.
Sorry. Dr. Abdualelah, you told us you sent for TDM, but what was the result?
Unfortunately, it wasn't sent. So at that time, it was lost because it wasn't available as a sent-out test outside the institution. So there was no TDM, unfortunately, to guide further treatment.
So back in 2022, I think we don't have any other medical option.
No anti-JAK yet, yeah.
Yeah, no yet. So I think the other option would be combined biologics versus surgery. Okay. Surgery not only in a form of a resection, also in a form of a diversion. Diversion might soothe everything down, but everything will be back once we do the reconnection. So just like we are buying time.
Okay. So just to answer the question of Dr. Sebastian, usually in those patients who are refractory, we tend to consult our immunology team who send post-vaccination titer, immunoglobulins, lymphocyte subsets, and then they move from there for a whole exome sequencing that was done for this patient, was negative for monogenic IBD or primary immune deficiency that could explain the patient phenotype. So that was done. The patient and his mother, who was usually accompanying him, refused the surgery. He had the stoma before, he didn't like it, and he didn't want surgery. So we discussed the combination. At that time, since the labeling was a failure to anti-TNF, the movement by the team was to go with a vedolizumab induction, then a Q8 weekly intravenous, since we didn't have the sub-Q that time. And this was added to sticknumab Q4 weekly, stopping the methotrexate. So 3 days, unfortunately, after the patient came with 15 times diarrhea, after 3 infusions of vedolizumab, 11 kg weight loss. He has hyponatremia. Last steroid was 8 months. We thought of adrenal insufficiency. So he was put in methylpred before testing, and he was following up with an endocrinologist. He was so sarcopenic with an albumin of 15. CRB was high. C. diff, since he had recurrent, was checked, was negative. A GR matrix BCR that usually covers 29 pathogens was negative. CT, there was no collection, no intra-abdominal fistula. He has a severe debilitating disease with severe malnutrition. So this is his scope, again showing the ulceration, and CMV is negative in the biopsy. We consulted the surgeon who discussed the patient and his mother about the surgery, and that if he goes for surgery, he will go for total colectomy, endoleostomy, refuse the surgery, in favor of going for maximum possible medical therapy. And again, we're talking here about a mid or first quarter of 2023. Regarding the fistula, was uncomplicated. They preferred not to go for any examination under anesthesia regarding the perianal fistula. Secukinumab was stopped. Vedolizumab was resumed. He was put on parenteral nutrition, supplemental, and enteral nutrition. He stayed for at least 6 weeks, mainly for nutritional support. So backline, PN, on top of EN. Then at that time, we started talking about anti-JAK. We started to have obadasitinib. Shall we start? He's on anticoagulation. He was on prophylactic. Then we discussed with them therapeutic dose. So would you go for anti-JAK? Would you go monotherapy anti-JAK? Would you combine?
Abdualelah, I think everything went wrong with him, unfortunately. So, honestly speaking, I don't think medical therapy might help. At this point, it's a bit early even to go for JAK inhibitor. It might help him, but with such extensive disease, in my belief, stoma, just because he's 15, he's in the maturity phase, he's growing. If he loses that, he will not get...
And he's already gained the expected height.
Multiple steroids and so on. So very logical to go for stoma, let disease settle, then consider medical therapy. Sometimes the parents do not agree or believe surgery is an option or surgery is type of treatment. Then this is the discussion we have to do, you know.
I think the decision initially for the video and the Stelara was not a strong decision, but honestly with an albumin of 15, infliximab won't work properly because the washout will be very extensive and the T-half of the drug will be very short in this case. Vido's out, definitely in this case. Whether or not I would use JAK, I think I would.
As monotherapy, or would you combine?
For him, I would use it as a single,
mono.
as a mono. He's already on anticoagulation. So what's my concern? Is it PE, DVT? He already developed it, and he's on therapeutic treatment for that. I think this is the only option that I have in this stage, especially as Dr. Muhammad mentioned, sometimes the family are very difficult to deal with, especially with the divergent stoma and so.
Okay, so for sake of time, the patient started on obadasitinib 45 on top of Vedo Q4. Again, 4 months after, he is still having active disease. He's now having a perianal drainage and abscess. Started in subphalangeal, waiting for MRI. Improved CRB with antibiotics. Still, this is showing fistula is not bad. There's no much of collection. This was scoped. An attempt for full colonoscopy was failed because of a left sigmoid ulcerating structure with a very bad disease. This is an OPA 45 off-label beyond 16 weeks and Vedo Q4. December 2023, the patient started on budesonide, obadasitinib 45, vedolizumab. He's still on combination. His MRE is showing worsening rectal and left chronic inflammatory process. And I will just hear, once I conclude the case, the thoughts about how to deal with such difficult patient and family if they are rejecting the appropriate treatment like stoma or surgery. But I will show you what happened. So the team decided to stop vedolizumab and to re-challenge with anti-TNF. They added adalimumab to obadasitinib, but they decreased the obadasitinib to 30. Now the patient in January 2024, this is 1 year ago, the patient had kind of like improvement, no complaint. Clinically, he's happy 2 to 3 times. This is adalimumab Q weekly with obadasitinib of 30, and he was scoped. Still the structure, the ulceration. There is no much of gain. In August, this is in this last summer, the patient was having loss of appetite, weight loss, despite OPA, 45 off-label and Humira weekly. He's on anticoagulation. He's having now an abscess in the perianal area. He was referred to the colorectal surgeon for examination under anesthesia, and the went scope again, still showing the severe disease, and no CMV, no C. diff recurrence. In September, December, the patient underwent examination under anesthesia with actually curettage showing the chronic inflammation with ulceration, granuloma, with many giant cells. And in December, he was on antibiotic. He was started on exclusive enteral nutrition, trying to spare him from steroid and OPA 45. And then they were discussing about infliximab versus something else. Eventually, the patient started on risankizumab, and this is the latest update. He's on OPA, risankizumab. He received so far 2 infusions. The latest update, as per this year, he gained weight. CRB is still in the 50s, ficaprotectin 700. So maybe just the last take-home message that one hear from the panelists, how to deal with such difficult patients while refusing surgery.
Yeah, first of all, be humble and know that we won't be able to solve everything and learn from this one. I would, for the moment, continue what we have and look for a clinical trial option for him if you have available. But these are cases which humble you, and let's all work together globally to solve these difficult to treat patients.
I agree on what Dr. Sebastian said, and I think sometimes it's the active inflammatory cascade in certain patients has not been hit. Like you don't know exactly whether his anti-TNF cascade or interleukin cascade is the one that's playing a major role. And you kept throwing the drugs to know which one might have an effect or like a synergic effect. In his case, he's a young boy with no such comorbids. Putting him on dual strong anti-biologic therapy in terms of UPA and RISA is a bit challenging, honestly. And I know that there is some centers that practice more of common combined. Where I used to train, it's not the case, but I think we don't have any other option in his case.
So Abdullah, thank you for showing us sometimes that we really fail, and not every case it's possible to treat. You know, that's we have to be logical sometimes. We just do see IBD patient that we can treat, but some patients it's really difficult to treat, even if you have all the medications. So.
Thank you, and I'm sorry for taking longer than expected. I apologize for this. Thank you for the panelists. Thank you for the audience.